towards the second session of the day.
Now, we warmly welcome Padmabhushan Dr. K.K. Talwar sir, who will be talking to us about technology and cardiology growth. Dr. K.K. Talwar sir is a cardiologist and electrophysiologist as well as chairman of PSRI Heart Institute in Delhi. He was a prime cardiologist for the first heart transplantation in India back in 1994, and he was also introduced the technique of radiofrequency ablation in 1993 at AIIMS. He was the first to implant ICD in India in 1995 and to introduce the CRT implants in India in 2000. He has been the former director of PGI-MER, Chandigarh, and is also a BC Roy awardee. The honorable chairpersons for this session are Dr. Sudhir Deshmukh sir, Dean, Dr. VMGMC Solapur, and Dr. Ritvik Jaikar sir, Deputy Dean and Professor and Head of Department of General Surgery, Dr. VMGMC Solapur.
Now, we request the chairpersons of this session to kindly come on the stage and accept our welcome. So please. Now, we request our chairpersons to kindly welcome our guest of honor of the session, Padmabhushan Dr. K.K. Talwar sir.
Sir.
Sir. Thank you, sir. Now we request you, sir, to kindly commence your talk. Over to you, sir.
Good morning, everyone.
Good.
Mr. Deshmukh, Sathi, Vice Dean of College, dear students, Dr. Gurnath, Academy, and it's a pleasure to come here, and it's my second visit to the college. Yesterday, when one of your students came to receive me at the airport, so she asked me, "You have been here once before. What made you come here second?" I was just wondering, probably this is what she meant, that why I am coming second. See, I must mention that I was really, this book was really, once first I was also surprised, but amazed also when first time I got a call from the student that we have a function, why don't you come and visit, and so that. I was wondering that normally from colleges it is the administration or principal will get a invitation, but the students are asking me to come. Anyway, having spent so many years in teaching, so I was really impressed, and I said, no, I must go and see what kind of enthusiasm. So I think what the effort, the enthusiasm, the passion that I saw in my communication with the students really impressed me a lot. And another thing I thought was their persuasion skills to persuade a person to come. So I was really amazed, and I think that made me to sort of come over again from Delhi and to be with the students here again and to share some of my thoughts. Today I am going to share with you how technology has helped cardiology particularly. But I think if you look at the last 6-7 decades, I'm sure all of agree, the huge advances. when I passed my DM cardiology, what was cardiology that time and what is now, it's difficult to even imagine that there will be so much progress. Not only in technology, even in medication. When I passed my DM, if I would have told the examiner that this is a patient with heart failure, I will give beta blocker, he could have failed. Majorly told me that this person doesn't understand what beta blocker is. And today, if a candidate tells the examiner that I will not give a beta blocker, he will give it. So you see how the things have to be, medicine is such an evolving field. And we have shared with you how technology has led us to the growth of cardiology and how it has helped us to serve the society, the patients well. Can I go to the next one, please? I think I've touched some of the areas in cardiology where I'll share with you how the technique has really grown and helped us. Next one, I think just now was mentioned that the ECG machines, original ECG machines. Oh, please go ahead. Next slide. This was the original ECG machine. It weighed about 600 pounds and has to be kept in a good. And this was again the continuous hard work of the innovative minds, the professionals. The biggest, they say, new thing came is the galvanometer which we record. That time the galvanometer was thought to be like capillary galvanometer, that you had to like put your leg, hands into the water to record an ECG. And Dr. Einthoven, Wilhelm Einthoven, he is the one who then, they say, invented string galvanometer. Today maybe, but that was late 80s and early 90s kind of thing. And then he fabricated this ECG. That is the record ECG. And we have this wave, QRS, and that what he named. And why he named QRS, I mean the QRS, nobody knows. He don't mention why he used this kind of terminology. So initially was mentioned A, B, C, D, E, but he changed it. And then we are also familiar with next one, next slide, that the Einthoven triangle. Next slide, please go ahead. This is the Einthoven triangle which is known by his name. And that's why we call the ECG leads, limb leads, and then also the recovery leads. Next one. So this thing, the galvanometer, they say, had countless evaluation in the research, but this became a university building as this place of research for scientists. Scientists from all over the world then went to this lab just to see the galvanometer. And of course, he got the recognition 24, he got the Nobel Prize in medicine. He is a professor of physiology. And see, look at his spiritual angle of as a human being. When he got the award, he was in that time in USA. He's a Dutch physician and he was working in the leading university. He suddenly thought of his assistant who was involved in fabricating this ECG. He said, I must share the award with him. And then he learned that he's no more. They say he gave half of the award money to his sisters, which were poor. And so that shows that these are the kind of gifted brains, gifted people who really had sort of how the science came. That's what. Now, as Dr. said, look at the now miniaturization of ECG. Now you have ECG portable ones. You have in a watch, smart watch, and so I think how the technology has grown. Now we can put a small patch on the body, we call external loop, and then record ECG for 1 month. So this this is how technology has grown and helped us to sort of, the ECG has become a very important, and now I think Dr. Kunal mentioned about the AI and the ECG. Next one. So this was the ECG that we had. ECG, we have limb leads, we have the caudal leads. Now, what more beyond this? You see, the people who were working in electrocardiology, they kept on thinking what more we can do. We had the information, we can diagnose hypertrophy, we can diagnose acute MI issues, we can diagnose arrhythmias with ECG. But what more we can do with this? Next one. And this is how the science grew further, that no, if we record intracardiac signal, that you put your catheter into the heart, and the record signals, you can record, and this was the first time after, it's a lot of hard work, experimental work, because before the human sort of evidence comes, this was the first time that Dr. Shagler put a catheter into the heart, at the his bundle, and recorded the his bundle. So now we know that the ECG is more than the ECG, that you can have the his bundle recording, will tell you infrared intervals, will tell you supra intervals, and we came to know that people who have a prolonged infrared interval may be more prone to AV blocks kind of disease. Next one. And then you can put catheter into each part of the heart. You can put into RA, you can put into his bundle, you can put into the coronary sinus to give intracardiac ECG of the left side, left AV valve, and you can put into the RA. So this made that beyond ECG we can go, we can have intracardiac signals which will help us to understand the mechanism or the underlying mechanism of various arrhythmias, whether it is supraventricular, whether it is ventricular. So this is how it grew. Now what further? So we knew that we can record these potentials, we can record these activities, we can say if patient has supraventricular tachycardia, what can be the possible mechanism, we can record ventricular tachycardia, say what is the mechanism, then what next? This is just to show you that the PR interval has a AH or HV. So this is how the understanding and the knowledge progress further, how we can sort of, we knew that if somebody has a prolonged HV interval, he may be prone to AV block and he might be a pacemaker. And then two new things have happened which further strengthened us how we can further help our patient community. One was the program stimulation, that you can put catheter, you can record activity. Then Dr. Gallen, again a Dutch cardiologist, that you can, by attaching a wire to this pacemaker, you can pace those chambers. You can give program stimulation to those chambers. You can induce tachycardia. You induce tachycardia like supraventricular tachycardia. You give a drug. You can show that if the drug is given, there will be no more tachycardia. So, but that is how how to manage or treat these patients. The program stimulation became next one. If you look at that, this is a patient who has a sinus ego, and then you give some kind of a pacing stimulus, you can induce the tachycardia. So you can induce tachycardia, and then you can give some kind of medication and see, now I cannot induce, it means that the drug is effective. So this is how we started learning that how we can effectively treat these patients. Next one. This is like we had it was all this knowledge made us to realize that the simple AV node has two conduction pathways, a fast conduction and slow conduction. Now if you, and that can be create a re-entry for tachycardia. And if you can block one pathway, you can block suppose the slow pathway, you block it here, there will be no tachycardia. This is the things we start learning. Next one, and this is again like we know WW syndrome. I show the from medicine residents or those who are in the final engagement know there's a pre-excitation kind of ECG which shows or WLP stem zone. We have an accessory connection across the atria and the ventricle which conduct very fast. So we can localize by this intracardiac mapping and say where is the path. The next, and these are the various catheters into the heart, like the next one. The next thing which sort of again hard work of many people was that you can, and this was a very accidental discovery. This in 1881, Dr. Gonzalez, when he was working in his experimental lab, they were inducing arrhythmias and shocking the animal. Suddenly his bundle catheter, which was at his bundle, got connected to the help of a catheter by giving a current from outside. So this led to this further understanding that we may not need medication. There are patients who have tachycardia, you know the place, you put a catheter, give a energy from outside and you can destroy that area. But only thing that was a DC shock. Next one. So, I mean, this is the first time they mentioned that in human being, closed chest ablation, just putting a catheter, attaching it to a defibrillator, you can cause a patient airflow. And this used to be needed sometime. Patients who have resistant tachycardias, medicines were not happy, they were very sick. So this was that by surgery you will open up and destroy that area. But now you can, by catheter you can do it. So this is how that is another way of treating these kind of patients with these kind of arrhythmias. Next one. I mean, it's just this bundle ablation and you get a block. Next one. So this became a very kind of a potent technique that using DC or defibrillator, you attaching a catheter, putting into the heart, you can ablate. And the only problem was that we were using DC shock. Now DC shock, if you, those who have used the defibrillator, it's a high energy and probably also cause some damage to the heart. Sometimes thin structure, it may rupture, even large lesion, and it's very painful. You have to give general anesthesia. So this was the limitation of using DC shock. But it certainly stimulated the minds of those who are inventors. What more we can do? Can we have an energy which can be safe and simple? So that led to the work of next one. People start working on the laser was tried, the radio frequency energy was tried, and it was on 1888. It was seen that radio frequency, which is nothing like a cautery, I'm sure surgical cautery you are using. The same cautery, little modification that you can attach to a catheter and give a lesion, a very localized lesion. Very safe, very simple. It looks very simple today, but you look at the over the years, the people who must have thought about this, that this is possible. Next one. So this is how the first RF rotation 87, 88 was initiated in first one pathway, and then we knew the understanding. Already you knew that you can understand arrhythmia's origin, and now we have a technique that you can cure that. I think probably to me, as a card, this probably was the one of the, I'll say, very remarkable that you can cure a patient. Most of the time, you give something, it may leak out. But here was one technique giving cure, and very simple, looks very simple today. Next one. So it's like an electric cautery. This frequency I mentioned that you only call electrosurgical desiccation. You don't cause any kind of burning, coagulation. So this is how this technique became possible. Starting from this ECG that you see, the intracardiac, and the next one. So this I think is the kind of radio frequency ablator that was available that we are using. Next one. And these are the catheters which the tip has that you can apply this to the connector and deliver energy at the tip and localize the cause damage to that tissue, and the patient will be cured of that kind of thing. Next one. This is the kind of catheter, the RA, his bundle, coronary sinus, the ablator catheter, because you have to identify, localize precisely the site before you give it. Next one, just to show you, this was the non-well it came to us. Significant tachycardia persisting ECG by say like I'm sure everyone that we say like reciprocating re-entry tachycardia. Next one, we did the, as I mentioned, that intracardiac recording, the intracardiac ECG, and we came to know what will be the possible site of origin of this tachycardia. And this was thought to be that coronary os, at the origin of coronary os, probably the focus which is responsible. I won't go into detail, which may not be possible to explain to you, but that was the site where we thought is the culprit accessory connection lines. Next one, and then you put your later at this RF ablation catheter, and we look at this is the tachycardia going. Here we try to give it start lesion, and within a few seconds the tachycardia goes. So this is how this. When kind of we have now a treatment where you can ablate these focuses and give a kind of a cure. But you look at the kind of period of over 60, 70 years, hard work of people who have really thought of and brought up this kind of a treatment. Next one. And this was the patient with the accessory pathway, just to show you the broad cure is a pre-excitation next. And then if you look at your mapping, intracardiac mapping showed that path, this is the V signal, this is the area so much that probably the pathway is lying very close to the ventricle here. And putting a catheter, you suddenly veins are very complex. Unless you have three-dimensional picture, you may not be able to. So I think then came this imaging system, and this non-fluoroscopic imaging system or 3D imaging system that we have now, and you can map these complex arrhythmias. Next one, quickly pass. Next one. So I think the patient young, BSF Jawan with ventricular tachycardia. Next one, and I think next, please go ahead. So this was the tachycardia kind of a ECG picture, and this mapping imaging tells you where is the earliest focus, and that's the sort of pink is the probably earliest activation, then it's spreading to the other part of the ventricle and giving lesions at that place, tachycardia ventricle. Next one. So now we have this kind of technology that you can map, identify arrhythmia from any chamber, and you can then by this simple way cure these patients. Next. So all kind of arrhythmia today are amenable to treatable with a simple radio frequency ablator, which is a procedure and is painless. Next, and we started this particular sort of facility names in 93 and 96. We published our 200 cases at that time. So I mean that shows what I'm trying to share with you, the younger mind, that people would think can do something about that. How people thought about that this was today looks simpler. But the amount of work that must have gone to sort of each step which has gone, how it has sort of created a science. Next one. The next, like Dr. Shishi briefly about the defibrillator. Now look, this was the first defibrillator, which was I think in 62, when Dr. Nordbaum is the main character to have established the DC defibrillator technology and showed it back. But she criticized and became smarter. Now we have an implantable kind of, that you like a pacemaker. You implant, is an ICD, patient has a VTPS, we take care of it. But see how this science came. Next one. So they mentioned that initially, I think they say in 1930, an engineering student at John Hopkins first fabricated an AC defibrillator, but AC defibrillator has issues. It's more damage caused to the sort of heart, to the structure, and then became the DC defibrillator, which we are commonly using in the life-saving equipment, and everyone knows about it. Next one. So what happened in, they say, Dr. Miroski was a cardiologist in Israel. He's a Jew. He was a Jew. I mean, they say at the age of 14 he has to run from Poland. His whole family was killed, and of course he, by God's grace, he took his saved and he landed in Israel, and then he was a his medicine. So one of his teachers, and who was also that time his slave, had a MI and used to have BPF, and couple of times in the hospital they had to Talwar him. So when he was at home one day, suddenly he had this BP. Before Dr. Mirowski could rush him to the hospital, he died. He then thought, suppose I would have a defibrillator by my side, I would have been able to save my friend, my teacher. This gave him an idea, why should not I work on to invent a defibrillator which can be installed. So 69, he went to John Hopkins, joined there, left Israel. They say the idea was born in Israel but was developed in USA. Anyway, he is there, started working. Everybody said this is even Dr. Long, who we credited with that, who is the did the defibrillator, is credited to his kind of a brain. He said it's impossible and it cannot, and it is unethical to put a device and to test it also in human being. I mean, this is an editorial he wrote once. But I think he persisted with this thought. He said, no, I must do, I need to manage some help. People, the industry was not supporting him. But I think some people came, people helped him. And then next one, it was I think first implant he could make, that he kind of device in mind. Now today, look at the defibrillator, what it is. And today, now you have a defibrillator, you don't have a pacemaker. Next one. Now we know how even leadless, that we cannot have a single lead into the heart. Even in subcutaneous ICDs, next. And we have no wearable ICDs. So how technology that somebody we know is a high risk. At the moment, we are not sure whether he should be given ICD or not. You can put this kind of a waste on him, he can be dominant. If he gets into this problem, the device will take care of it. So what I mean to say that how technology over the period, and this only reflects on the human minds, people who have struggled, who worked hard to innovate, do these kind of things and made it possible. Next one. I mean, we did our first implant in 95 and then the cardiology they came in leaves. Next one. Now I'll talk about the cardiac catheterization. I think this is the routine procedure the last day. But look at how it came. Dr. William Fossman was, they say, in the lab itself. He was a young doctor, like some of you. He put a catheter, a logical catheter into the frog's vein and pushed it and it went down. So he said, why can't, he got obsessed that I must do it in a movie. But he was dissuaded by everybody. He said, it's an insane idea, don't do this. But he persisted, no, I must sort of do it. And one of the ward sister or the theatre sister, he could convince and she agreed to help him. So on a day when nobody was there in the theatre, they say he did his cut-off, antecubital vein, and the sister gave him this catheter, logical catheter, size-wise was fitting into the vein, and he pushed into through the vein, and both he and the sister quietly went to the radiology. Then no one able to see what's going on. And the X-ray was there. And then you see the catheter was in the right hand. Next. Next one. So this is the kind of catheter which was. So I think the next one. He wrote later on, I felt that I had planted an apple orchard. And other men who had gathered the harvest stood at the wall, laughing at him. That time everybody dissuaded him from that. But later on he said, so what I mean to say, this is how are these innovative young minds, which I think we need to invest on. I'm sure some of you will get stimulated to what I think for the future. And the first one, I think there is a saying of Foster's family archive. It's interesting to read. He was working as a young intern at the August Victoria Hospital in Germany. I was the job was hard and often required him to work all day and night without a break nevertheless. Today तो हर एक रेजिडेंट कहता है मेरे को जॉब चाहिए. I'm not joking. This is I mean, if you have to slog, you slog. You want to do something. Nevertheless, he was pleased to find a sense of openness among his colleagues and described the situation at the hospital as precisely the sort of environment in which good ideas could come to fruition. So you need to have an environment where so this is how this beginning of cardiac catheterization started. Next. And then the seamless media machine, angiographic machine, next one. And so it was in 56, Dr. Forsman and Dr. Purner, Dr. Richard, they were other working in Philadelphia, and they both worked on further on cardiac catheterization, even a Purner catheter. So they were rightly awarded the Nobel Prize in medicine. I think gradually, I think today angioplasty has become such a sort of important therapeutic option with us. It was again Dr. Daughter who thought of that we can dilate the narrow vessels, and the next one I will quickly go through. This Teflon catheter that he fabricated and a narrow limb artery, he passed through it and showed that you can dilate this. And that's what stimulated of bleaching. And we did the first coronary angioplasty in 1977. Of course, we know that balloon angioplasty resulted in restenosis in 50-60% of the patients. Then what further? Then came the concept of why don't we put a stent, which that may prevent restenosis. And then we have the bare metal stents. And again was found that they may also cause stenosis in 20-30% of individuals. And then drug-relating stents, whatever, how the science grows with more and more understanding. Next. Briefly about this particular thing, this is again the heart failure issue. I think it's an epidemic today, and we know that we have a number of drugs, we have a number of surgical procedures, we have devices like CRTs, we can ablate some arrhythmias which may be causing heart failure to give a cure, but even then people go on to worsen, and the transplantation was the only option. The transplantation is limitation, it's a availability of heart is limited. And so then there was an artificial heart, why not be so this is how the artificial heart first came, and people were working in 60s. Next one, that was in 62 after Leota, and Cardiology medicine fabricated that device which can be put into the heart and may support the heart. And that became mechanical support devices. And then the first device was implanted by Dr. Leota and Dr. Devake. But I want to emphasize subsequently NIH, which is the government organization, they granted $6 million to Boston Children's Hospital and Cardiology to have a device which will be long lasting. And thus they came out with this further refined, next one, and we have these implants which became heart rate 1, 98, I think it's initiated. Then heart rate 2, heart rate 3, now we have next one. And we were fortunate also in aims that we got these heart rate 1, 4 or 5 donation from the company to try. And this was one of our patients who lived for 2 years. I mean, he was waiting for a transplant but had a thrombus. So, I mean, this is how today we have a device which is small and we put it in the body and it's like a destination. Even next one. This was another patient in 2015. And the next, this is a new device that he was given. And today we know that these devices will as well as partners not on a long term. Next one. So this is what I wanted to share with you, that as far as technology advances, but I think we must salute the human mind, human beings, whose perseverance, whose passion, and whose hard work trying to produce new things, think of new things. And that's what I think. Of course, AI, I will not talk about. It has its original data. Next one, I would really like to show you slide next. Okay, the next one. Next one. No, please. I think actually also next one. So when we mentioned about the ECG, and these are the publication indicating, as you rightly said, AS, erection fracture, critical diagnosis, anemia, breaking AF, predicting diabetes or pre-diabetic stage, feeling pressure, hyperthyroidism, kidney disease. This is the kind of, I'm talking of the publication which has come up. On that with the simple ECG, you may be given this kind of information. Next one. This is the retina. They say you can't of diabetes, kidney disease, liver and gallbladder disease, for example, retina, AI issue, heart calcium, Alzheimer's disease, that you can protect that patient may be prone to it after some years. So this is the kind of information which is coming on the basis of analysis of AI. But of course, next one, I think there are challenges, as have been already emphasized by him. I think accuracy of the data is very important. Whether you can translate the data one race to the other race is another going to be question. So we need to have our own data if we have to grow up with this field. And I'm happy that some of the labs like himself has it and a huge amount of data. They say there are huge number of death occur because of medical error. And that's because, so I think if AI can help us to minimize those errors, I think that would be great. Of course, it's in infancy, so looks very promising, and I'm sure the next decade or so is going to be the decade of AI. I like to just say the medicine room is science, but the practice of medicine is art. And machine cannot learn art. Machine can only learn what it is. It is a human mind, a human brain. But of course, machine learning, machine eye is very, very important. That may help us, as you mentioned. This may help us to further strengthen our ability to do our best to our patients. Next one. Just for some Indian contribution, I think I must say, Chitra Hartwell was one, which was in Jayadeva, institution, Dr. Valiathan, who was the director, founding director. He was again, I think, one of our right wing. He is the right wing. He's the one when this institution was initiated. He wanted it to be under the Department of Science and Technology. He said that department interferes. And so Chitra is under the Department of Science and Technology. And he built up a biomedical engineering field and worked on it for 10 years to produce one individual for Chitra Hartwell, and is now, I think, it's very cheap as compared to other guys, and probably encountered a large number of very good kind of a long-term care. Next, that was another was Indian stand. This was again our former president, Dr. Abdul Kalam, when he was working in the RDO. He spoke to Dr. Raju Gandhi. We have been colleagues in PGI, Raju is another. So we were together, RD, and that why I know from Dr. Kalam asked him, why can't we make this thing? And the DRDO then started working. That was the first Kalam Raju stand which came. And then after we have more other stands, we have the cross-surgeon company, we have the Patavi webs and all that. So I think there is a going on. But what I do wish, and I pray our young people to think originally. To think something that probably, I think we have now reached a stage that, we have to be leader in medicine, we have to now
invest into our youngsters, give them the environment, give them the facilities, they can think about out of the box and do newer and newer things. I think I'd like to just a couple of these slides that medical college should have a research and innovative unit to encourage the participation. I think this, and the medical college should collaborate with all another institutions around. And that's the way we can give our youngsters more kind of a way to sort of stimulate them and see that something more. Next one. There has to be more collaboration with the basic science institution, which is, I think, is going to happen. Like even in AIMS and PGI, I spent my whole career, we were isolated. I mean, later part we did try to interact with IIT, to do something. So I think we need to develop more interaction with our engineering minds, the medical mind, to work together, science or maybe the pharmaceutical science, so that we can think of newer things, and I will say the scientific body has to create this kind of environment in our colleges to stimulate our young minds. Next one. I think we need to have a mindset to we must dream, youngster must dream and do this program. Dedicate and devote. Never think of never think of that I'm doing my duty that tomorrow. Think of what more you can do. That's the stage that you can sort of do fruitful efforts to reach destination. I think before. I'd like to use this line for our younger people. In research, success and failures are facts. Unfortunately, whatever I have seen over my course with decades of my career, we don't respect failure. Unless we respect failure, we cannot get success. So in research, sir, personally working for a number of years may not come me something. But that's we need to respect failure if we have to be innovative in research. Don't lose nerves in failure, think and proceed. Now of course, be humble in success. And success is not final, and the failure is not fatal. I think I like that these we have to convey to our young generation. I think I see your enthusiasm, your efforts. I'm sure the future is bright for us, that we have young people who have passion and think. But I'll say, end this with a very famous quotation: the genius is 1% inspiration, and 99% is perspiration. And I think probably in my experience, this will be one of success. Thank you so much, Talwar.
Thank you, sir, for enlightening us with the ocean of knowledge that you have surely encompassed over so many years. The floor is now open to the respected chairpersons.
In today's session of Hirak Summit, second day, we are honored to have a speaker like Dr. K.K. Talwar sir, who had been awarded Padmabhushan, who had been chairman of MCI, who had been the chairman of PGI Chandigarh, and much more. He has enlightened us today on the history of ECG as well as the mapping of the heart externally, internally, as well as the various developments in the treatment of the arrhythmias, like the AR, that is ablation therapy, how it was developed throughout the years together, and the development of recent things in this. And he has also encouraged our younger doctors for future generation to align with the AI. AI is coming up, but it is in childhood, so definitely we should take care. We are more important, our mind is more important, because we have innovated all these things and we are going to develop and use it as an aid not everything is AI, but you have to use it as an aid, minimize your complications, increase your accuracy. That is what the technology is telling us, I think, right now today. Things may change in future, but today's message is like this. So we are very much honored, sir, and delighted to welcome you in our institute, that is Dr. Vaisham Fine Memorial Government Medical College and General Hospital, sir. Thank you so much, sir.
Topic is open for discussion. Any questions or welcome to the audience?
Someone from back, young minds, anything you would like to share or say? If you want to say something.
Usually, sir, when we invite some guests for any program or any institute, usually the organizers also don't ask them again, and usually the guests do prefer not going again. But then, as you mentioned in the beginning of your talk, that something like how a grandchild asks for a grandparent and he cannot deny, and this is how you have accepted our invitation and over 12 hours of journey. And after that, when we requested sir to just visit the venue, because it would be a very busy day today and we are experiencing it, and he very politely agreed. And this humbleness we don't learn in any institute and in any textbook, and this is to be learned only from the lives of live legends, and we are very much bestowed and honored to have you, sir. So thank you so much, sir. And for this talk, in which we could see the complete film of development of cardiology and ECG as such, I think we can all stand and give a standing ovation to sir for this wonderful talk.
But Rohit, don't just say that you remind me that I'm of grandfather age. So actually among youngsters you feel that to be on. Thank you.
Dear students, you are indeed lucky. You don't know who Dr. K.K. Talwar is. He is literally a legend, an idol for many of us cardiologists. We have just been hearing him for so many years. So you are indeed lucky that he did come all the way. So this itself should serve as an inspiration for you, as he said, to develop new ideas, do something that will contribute to the society. He is literally a legend. Okay? So again, I wish you give a standing ovation.
Fantastic journey down the memory lane from the veins of Frostman to all the newer AIDs and other things. We are really proud that we could listen it from the real, the master of the subject, and you have seen the evolution of cardiology in the country. And so many firsts on your name. We are indeed very lucky, and thank you very much for it.
Now we request the chairpersons to kindly come on stage and felicitate our guest of honor, Dr. K.K. Talwar, sir.